So, hello and namaste to all of you. This is Name-Shalu Singh from Department of Physiotherapy and Diagnostics in Jayoti Vidyapeeth Women's University. So, for today's lecture, I'll be talking about metabolic acidosis. So, metabolic acidosis is one of the chemical pathology of acid-base disturbances. Earlier, we have seen that there are two classifications of acid-base disturbances. One is acidosis and the other one is alkalosis. Now, this acidosis, it is further subclassified as respiratory acidosis and metabolic acidosis. So now further, let's see what is metabolic acidosis. Metabolic acidosis, it is due to the primary deficit in bicarbonate, and this may result from an accumulation of acid or depletion of bicarbonate. And when there is excess acid production, the bicarbonate is used up for buffering. And depending upon the cause, the anion gap is altered. Now, what is this anion gap? Actually, the sum of cations and anions in ECF is always equal. So, as to maintain the electrical neutrality, sodium and potassium, they together account for 95% of the cations, and whereas chloride and bicarbonate, they account for only 86% of the anions. Now, only these electrolytes, they are commonly measured. So, there is always a difference between the measured cations and anions. So the unmeasured anions that they basically constitute of your anion gap. Now it is due to the presence of proteins, anions, sulfates, phosphates, and organic acids. So basically these are your components which cause anion gap. So these protein anions, your sulfates, your phosphates, and your organic acids. Now, let's further see that the anion gap has its normal value. So the anion gap, when it is calculated, as I said, that it is the unmeasured, or it is the difference between the measured cation and anion. So in case of cation, when we say cations, we'll say most common cations will be a sodium and potassium. And when we say anions, the most common anions will be a HCO3 minus plus chloride. Now the difference between sodium, potassium and bicarbonate and chloride, it is 12 millimoles per liter. Now, this is the normal value. Any increase in this normal value or any decrease in this normal value will indicate your pathological conditions. So, there are two types of anion gap. This metabolic acidosis, when there is high anion gap, and other case can be when there is normal anion gap. Okay. So doesn't mean if there is normal anion gap, there is no pathology. So there can be a pathology in case of normal anion gap. So first of all, what is high anion gap metabolic acidosis, or HAGMA? It is basically the value between 15 and 20, and it is accepted as reliable index for accumulation of acid anions in metabolic acidosis. Now, the causes of this anion gap can be two. Number one, it can be renal failure, where the excretion of H plus and as well as generation of bicarbonate, they both are deficit. Now, the anion gap, it increases due to accumulation of other buffer anions. Now, your next case can be of lactic acidosis. Now, what is basically lactic acidosis here? Normal lactic acid content in is in plasma is basically less than 2 millimoles per liter, right? So if it is increased in it is increased. So as in case of tissue hypoxia, or in case of circulatory failure, or it is in case of intakes of biguanides, then this can be a case of lactic acidosis. So lactic acidosis, it causes raised anion gap, whereas diarrhea causes normal anion gap acidosis. Now, lactic acidosis, it can be of basically two types, type A and type B. So, what is a type A lactic acidosis and what is type B lactic acidosis? So, type A lactic acidosis is impaired lactic acid production with hypoxia, and it is seen in case of tissue hypoxia, that is in your case of anaerobic metabolism. Secondly, in case of shock, like in case of anaphylactic, septic, and cardiac cases, in your lung hypoxia, in your carbon monoxide poisoning, in case of your seizures. Now, when there is type B lactic acidosis, there is impaired lactic acid metabolism without hypoxia. And this can be seen in cases of liver dysfunctions, toxins, alcohols, inborn errors, and might secondly in case of mitochondrial disorders. So less oxidative phosphorylation and more of anaerobic glycolysis. Next case is of Theomen deficiency. So there is defective pyruvate dehydrogenase deficiency, right? So let's just suppose that there is 5 millimoles per liter of lactic acid that has entered in your blood. Now, this is buffered by bicarbonate, and it will be resulting in your 5 millimoles of sodium lactate and 5 millimoles of your carbonic acid. Now, the carbonic acid is dissociated into water and carbon dioxide. This part I have already shown you in one of our last classes. So you can look at to that flow chart. Now, this is removed by lung ventilation. Now, the result is a lowering of bicarbonate by 5 millimoles and the presence of 5 millimoles of unmeasured anion, which is your lactate, with no change in sodium or chloride. So anion gap is increased, and in contrast, diarrhea, and which will result in loss of your bicarbonate. So sodium chloride is reabsorbed more from kidney tubules to maintain the extracellular volume, and will result in increase in serum chloride. And now this chloride will compensate for your fallen bicarbonates. So now diarrhea will result, which will result in hyperchloremia, because in case of diarrhea, there is excess removal of water, right? So chloride ions, they will increase in your system. So it will lead to hyperchloremic, now normal anion gap, and metabolic acidosis. Now, this gap may be apparently narrowed by cations such as potassium, magnesium, calcium, and these are decreased. Or when there is hypoalbuminemia, similarly, there is elevation and is seen in hypergamma globulinemia, when positively charged proteins are elevated or when cations are increased. Cations like potassium, calcium, magnesium again. Or in case of alkalosis, when negative charges on albumin are increased, right? Now, the third cause can be of your diabetic ketoacidosis, right? So, what is a diabetic ketoacidosis basically? It is basically the case where which is very life threatening, and it can affect people with diabetes. So it occurs when body starts breaking down fat at the rate that is way too much fast, and the liver processes this fat into fuel, which is known as ketones, and which causes blood to become acidic, right? And diabetic ketoacidosis, it can be treated with your insulin. Fine. Now let's see the other causes of your this thing, hyper anion gap metabolic acidosis. Now the next case can be of your ketosis, and it is remarked by acetoacetate, your beta hydroxybutyrate anions, and it can be seen in cases of diabetes mellitus or in case of your starvation. Now the next cause is your salicylate, which is in case of aspirin poisoning, and now next case can be of your amino aciduria, which can be seen or which can be remarked by the cases of acid metabolic intermediates, accumulation due to block in normal metabolic pathway. Organic acidurias is also one of the cause, and it can be seen in case of organic acid, methyl malonic acid, propionic acid, etc. So more other causes can be of your methanol, like in case of alcoholism and drugs. Now methanol, it remarks formate your glycolate, oxalate ions, and acids formed lead to increase in Ag and increase in plasma osmolality, osmolar gap. Now further, so drugs, for drugs, the remarks could be your corticosteroids, dimethaprol, ethacarbonic acid, furosemide, methanol, nitrates, salicylates, and your thiazides. Now, renal tubular acidosis, it may be due to failure to excrete acid or to reabsorb your bicarbonate, and chloride is elevated, or since electrical neutrality has to be maintained. Now, in case of urethric transplantation, the chloride ions are reabsorbed in exchange for bicarbonate ions lost and leading to your hyperchloremic acidosis. There is acetazolamide therapy, and this acetazolamide therapy, it results in your metabolic acidosis because HCO3 minus generation and H plus secretion are affected. Now, in case of urine anion gap, which is also symbolized as UAG, it is useful to estimate the ammonium excretion, and it is further calculated as your capital UAG, okay, urine anion gap, and it can be also said as UNA, urine sodium plus UK, that is urine potassium, minus UCl, which is urine chloride. Now the normal value is minus 20 to minus 50 millimoles per liter. And in case of metabolic acidosis, the ammonium chloride excretion increases, and this urine anion gap, it becomes minus 75 or more. Now, now there is in normal value of minus 20 to minus 50 millimoles. So in metabolic acidosis, the ammonium chloride excretion increases and urine anion gap becomes minus 75 or more. So, but in case of your renal tubular acidosis, this ammonium excretion is defective and urine anion gap has its formal value. Now, what are the causes of renal tubular acidosis? See, first one can be this renal tubular acidosis. It can be of two types: either proximal renal tubular acidosis during in your proximal part of tubules, or it can be of type 2 distal renal tubular acidosis. Okay, or thirdly, it can be of your type 4. Now, type 1, it has causes, this can have causes like multiple myeloma, amyloidosis, heavy metals, lead, mercury, Wilson's disease, galactosemia, hyperparathyroidism, paroxysmal nocturnal hemoglobinuria, acetazolamide. For second type, that is distal renal tubular acidosis, it can be autoimmune disorders, your SLE, rheumatoid, hypercalciuria, amphotericin B, lithium, obstructive uropathy, Marfan's syndrome, and for type 4, it can be impaired aldosterone function, right? Now, decrease in anion gap, the term which I told earlier, it is seen in case of your hypoalbuminemia, in case of your multiple myeloma, in your bromine intoxication, and your hypercalcemia. Now, serum albumin levels and anion gap, if we say, so in that case, normal anion gap is affected by patient serum's albumin level. And as a general thumb rule, the normal anion gap is roughly 3 times of your albumin value. And further, let's see what the example is like. If a patient with an albumin of 4.0, right? Now that patient with having anion gap is will be 12, right? Because that is the normal value, 12 millimoles per liter. Now for a patient with chronic liver disease and an albumin of 2.0, the upper limit of the normal range of anion gap would be 6, right? It won't be 12, it would be 6. Now the ceiling value of normal anion gap is reduced by 2.5 for every 1 gram per deciliter reduction in your plasma albumin concentration. So it keeps decreasing with respect to your plasma albumin concentration. Now there is another term which is called osmolar gap. What is osmolar gap? See, it is the difference between measured plasma osmolality and calculated osmolality, and it can be calculated as your 2 into concentration of sodium plus concentration of your glucose plus concentration of your urea. Now, the normal osmolar gap, it is less than 10 milliosmoles, right? You have to remember the normal values, which is very important. Now, a high osmolar gap of more than 25 implies that presence of unmeasured osmoles such as alcohol, methanol, ethylene glycol, etc. Now, in case of acute poisoning, it should be considered in patients with raised anion gap, metabolic acidosis, as an increased plasma osmolar gap. Now, poisoning with methanol and ethylene glycol, it should be considered, and they are metabolized to formic acid and oxalic acid correspondingly. Now, methanol, it will produce blindness. Ethylene glycol, it can lead to your oxalate crystalluria and your renal failure. Now, we have got to know these terms. Now, further, one of the most important term that we come across is what is your compensated metabolic acidosis. So, if there is decrease in pH in case of metabolic acidosis, it stimulates the respiratory compensatory mechanism, and it will produce hyperventilation, cosmos respiration to eliminate your carbon dioxide, which is leading to your hypokapnia, right? Now, PCO2 falls, and this would attempt to restore the ratio towards your 20. Right, we during bicarbonate and carbonic acid ratio, I told you earlier also that the ratio is 20, which is now the partial compensation. Now, what is renal compensation? Increased excretion of acid and conservation of base occurs, and sodium hydrogen exchange, ammonia excretion and bicarbonate reabsorption are increased. So as much as 500 millimoles of acid is excreted per day, And the reabsorption of more bicarbonate also helps to restore ratio to 20. Now, renal compensation, it sets in within 2 to 4 days. And if the ratio is restored to 20, the condition is said to be fully compensated. But if unless the cause is also corrected, the restoration of normalcy cannot occur. Now, in case of association with hyperkalemia, hyperkalemia means increase in your potassium levels. It is commonly seen due to redistribution of potassium and hydrogen, and the intracellular potassium, it comes out in exchange for hydrogen and moving out into the cells. Now, hence, there is care should be taken while correcting acidosis, and which may lead to your sudden hypokalemia. Hypokalemia means decrease in your potassium levels. So this is more likely to happen in treating diabetic ketoacidosis patients because they'll be given glucose and insulin all together, right? Now, however, changes in albumin level or changes in negative charge on the protein molecules can give unaltered anion gap values, and therefore the pH increases the anion gap and may show an increase in hypoalbuminemia anion gap, and it will show a decrease. So, in order to overcome these difficulties, a new term was set out, which was strong anion gap or SIG. So, this strong ion gap, it has been introduced, which was further corrected to AG, which was called as anion gap. So now, what can be the clinical features of metabolic acidosis? The respiratory response to metabolic acid, it is due to hyperventilation, and so there is marked increase in your respiratory rate and in depth of your respiration. So it is called as Cosmos respiration, and the acidosis is said to be dangerous when pH is less than 7.2. So serum bicarbonate is less than 10 millimoles per liter, and in such condition, there is depressed myocardial contractility. Now, what could be the treatment of metabolic acidosis? So, treatment is to stop the production of acid, okay, by giving IV fluids and insulin. And oxygen is given to the patient with in case of lactic acid accumulation or lactic acidosis. So, with in all the cases of potassium status to be monitored, so that hypokalemia and hyperkalemia, these has to be monitored now closely, and they need to be corrected. Now, bicarbonate requirement, the amount of bicarbonate required to treat the acidosis, it has to be calculated from base deficit. Now, in case of acidosis, milliequivalents of base needed. So, body weight in kgs into 0.2 minus base excess in milliequivalents per liter. So, this was all about metabolic acidosis. It is a still very wide topic. So, you need to read it very carefully and you need to focus on it. So, if you have any doubts, you can further contact me. And until then, take care.